everybody. Happy 2025. I hope you made it through the holidays, had a great holiday season and a happy new year. Dan and I ended up spending a little bit of time in Hawaii together.
I think we did one right when we came back, remember? Didn't we?
Did we? I don't think we did. Did we film? This is the first podcast of the year. Yeah, because, see, that's how discombobulated you are with the holiday seasons.
Thought we did talk about that.
Yeah, but happy to be back in the saddle, ready to go. Give you guys some updates for kind of some of the things swirling here that we have going on, getting into 2025. But we're ready to get going. Dan, what do you have on your agenda today for today's podcast?
I mean, for anybody really who's going to skip ahead or whatnot, what we're going to be talking about today is just the value-based insurance design, like what
VBID.
VBID, what that really is, what that really means, and really dig into the weeds on it. And this is really what I think a flagship moment. It's really important that we talk about it. I think it's getting not enough attention in the news and the headlines and the broker community. The carriers, I'm sure, are all, in heavy discussions.
Yeah, they're
about
scrambling.
This. But I think for the average broker, they don't know. So we're going to be talking about that a lot today in depth. But before there, like housekeeping items, I want to talk about one important thing, AE. So if you're an agent out there selling ACA or IFP plans, we use a lot of acronyms on this podcast, but the individual and family plans, health insurance plans that are on the marketplace, subsidized health insurance plans, whatever you may call it, that is ending on the 15th, okay? So we only have a couple more days as we're recording this podcast. We're right at the home stretch. Any of those plans that brokers are writing right now are going to go into effect on February 1st. A couple of things there, just from housekeeping. Binder payments have been a huge issue. I talked about it once already in a prior episode. We have been having massive issues and have been talking to carriers with very little success in that we did not write our policies in NPN override. We tried to let the actual writing agent have accountability for their own NPN and write the policies under theirs. And as those agents of ours either get terminated, they leave, or we give them a release to another FMO, or their employees, and we terminate them, we're having a real challenge of getting carriers to recognize that, understand it, then move the book of business or associated policies under us as a house account and allow us to auto-renew and service those policy members. It's requiring a one-to-one call for every single policy to CMS or to the marketplace. And you're like, well, that's fine, but it's not fine when you're a large entity and you're talking thousands of policies. It's not achievable. So,
well, I don't know anybody that likes having to call into CMS to do something that should be easily, quickly, efficiently done.
Yeah, normally if you're a broker, you just go into your health Sherpa or the carrier, you can just see it, and you can auto-renew the plan first and then talk to the consumer and said, hey, man, I got you set. Your plan's set to renew. You're good to go, but let's have a discussion and see if that's still meeting your needs, or if you'd like to move to a different metal tier. Let's make sure you still have access to where you want, but at least worst case scenario, your plan's not going to get canceled and you're auto-renewed. That's great, but that's not applicable, and that's what we want to do. From an operational or industry design right now, it's not there, and it's a mess. And for those people listening, we're trying to communicate and convey and move that progress forward. So that's one thing that's a big issue right now on the marketplace. Secondly, CMS right now should be about 7 days normally on applications. It's 14 days. So when somebody writes a plan, let's just pretend Oscar or United Healthcare, and they enroll somebody, the marketplace will transmit that over to the carrier. They're now 14 days before the carrier receives it. So if you're doing your math there and you get a plan and you're like, hey, Bobby, I got you set up on this health insurance plan. It's going to start the first of the month. Well, it's now 14 days before the insurance carrier is even getting that data that they've received an enrollment from the marketplace. And it sounds like it's a mess right now. So I'm just putting that out there to you all, that because of those delays in timelines, it's probably not the carrier that's screwing it up. They're probably really behind getting the data from CMS.
Yeah. So in short, the ACA open enrollment period was a little bit challenging this year. We knew it was going to be challenging coming in with some of the past, how rampant the fraud, waste, and abuse, and a lot of the changes that needed to happen. But as it played out this year with a move, famously we talked about Georgia moving to state-based exchange, and that's been a mess. And there's been a lot of different things that have been chaotic and challenging. And one of the things overall that was it's done two things in my opinion, is agents that were newly looking at jumping headfirst into the ACA space. They're kind of a little bit more like, maybe I'll not, make my whole business plan transition into that. And it honestly has kind of frustrated some of the agents that have been doing well in the ACA for the past 6 to 8 years. It was pretty smooth for them, until it started really growing and getting more chaotic. And now this, the past 18 months, it's been very difficult for them. And so it's frustrated a lot of those great agents and agencies too, which is a little bit, disheartening. But so needless to say, there's a lot of things to be cleaned up on the ACA side of things. We're both very, very bullish on the ACA, on the industry overall, on the future, and just maybe adding on a little bit there too with the change in the administration coming up. A lot of indicators or statistics are showing that there's probably likely going to be bipartisan support for the subsidies and for the ACA going forward. And in fact, I'd seen a couple statistics shared around online that the ACA actually grew more in red states than it did in blue states this year. So, obviously people are utilizing it. People are liking it, solving a need in some way, shape, or form. There's just a lot of ironing out still to happen. But I think that's going to happen. We're going to start seeing a lot of progress there in the next 18 to 24 months.
Yeah, I would say so. So remember that. I agree with the ACA. Also remember, you mentioned Georgia. Another little side note, it is still pretty open. We're seeing a lot of fraud in Georgia because they're new as far as an exchange, and it was a large state. They're a state that typically the carriers pay a pretty high commission in as well. So because the commissions are higher, it's facilitated through Health Sherpa as a vehicle to write. A lot of other private exchanges have other avenues to write business because it's Health Sherpa in Georgia. Because of that, we're still seeing a lot of the fraudulent activities, that were happening in the FFM. We're seeing it in Georgia. Like, I can tell you firsthand, we would go and write 500 apps, and a week later, 100 of them are gone, just like that. So that is one thing to keep your eye on for those listeners, for people who are thinking about business strategy, people who are regulators or carriers. That's something we've really observed in Georgia as well. So again, it continues to be messy. And you touched on one thing that we probably should mention as well. We tend to try to stay fairly neutral when it comes to talking about politics, but it affects our industry. It affects the policy making. It affects everything that we do in a supply chain in that cycle. And so one of the things that I think is important to also understand moving forward is I think that we are going to see over the coming years a lot more of the federal does not want to make the decisions. They're going to kick a lot of things to the states. And so living in this, constitutional republic, like, we're not a democracy, we're that constitutional republic. We have state rights, and you're going to continue to see a lot more variation, I believe. So when you start to look at the regulatory environment over the next couple of years, and everybody's discussed, well, what's going to happen? Oh no, and everyone's terrified. I think the biggest overarching theme that we're going to experience is more of an element of let the states decide. And so I think we're going to see a lot more variation in how things are administered, and even from compliance, reimbursements, how programs are run, enrollment period. I think we're going to start to see, it's good and bad, right? I mean, that states have the ability to do that. It is going to be more challenging, I think, over these next couple of years for large entities who operate in a lot of different states. That is one thing that I think we should all be preparing for. So
yeah, it's interesting. Just before we start talking about all the VBID stuff with the upcoming administration, there's all sorts of plans and suppositions of what's going to happen and things like that. But it's actually been, someone was reaching out to me today about what's going to happen in the very near future, and it's actually been relatively quiet, right? We haven't heard a lot of actual information coming out from the incoming CMS and HHS directors about some of the changes that are likely to happen. And then you have the whole component of, Elon and the Doge department and what, stripping back and eliminations of things there may be. But as of right now, at least as far as like how it affects the healthcare industry, the ACA, Medicare, it's pretty much a black box of what's on their mind.
And still be really careful about what you say, because, we heard over the last week too that Mark Zuckerberg said that, we're not fact checking anymore. Those people that were fact checking, those people that are our people, those people over there that were fact checking you all, we're not going to do that anymore, and suppress and all that stuff. But I will tell you too, even on this podcast, we've had to move things to X and other platforms and social media. So we still have to be really cautious, even to date, about all the things that we say, but hoping for the ability where we can more freely discuss things and not be cautious about keywords and all other things, that as we want to really dive in and provide you all, our listeners and audience, with, just a good overall understanding of our industry. We hope we can do that with less restrictions.
Yeah, and we are 11 days out from the inauguration now, and so the next couple of podcasts that we do, we'll probably start having some initial salvo of changes that may affect our industry. However, as we said it right now, there's not a lot of things that we know about and how it'll affect our industry. But one thing I do want to point out, and this will play in as we do talk about VBID, is the table and the stage is set already, because the current timing of the industry is all of these carriers, they're already gearing up for 2026. And that's why we wanted to talk about VBID today.
Yep.
Even though there isn't a new incoming administration, there's only so much, and the timeliness of this industry, these carriers are already about to enter war games. They're already examining the benefits and how things work. They're reacting to the
bid plan design.
Correct. And they got this, literal grenade dropped into the industry on this current administration's way out the door of basically the stripping back of VBID that had become a pretty critical, integral part of the bid process and part of Medicare Advantage plans.
Yeah, maybe before we dig into that, let's wind it back. Wind it back a little bit and provide a little bit more context. And this is not, and I always put disclaimers out here for people who really tune in and listen to our podcasts. I'm not trying to tell everybody that I'm the guru and I am the ends-all be-all to this, but I really do have a good understanding of VBID. Like most concepts, there are certainly more educated people out there, but we want to give you somewhat of an understanding of it. So if you really look at Medicare Advantage plan design, and going back to 2017, they introduced this VBID model, value-based insurance design. Mm-hmm. And with the theory of, value-based care, and they wanted outcomes, right? And they wanted to pay more for certain things that are achieved, but also they wanted to solve certain social determinants of health or people with higher risk conditions, right? So they wanted, with the premise being that if you have one patient who is diabetic and has neuropathy and has all these conditions, obviously that person is going to have expensive medications. They're going to be more prone to hospitalizations. They're going to need more health care than just another consumer who goes to the doctor once a year and doesn't take any meds, right? I mean, we can all agree that was the kind of the thought or the premise behind it.
And it was passed bipartisan, bipartisan legislation.
Yeah. So it was kind of like, hey, let's all recognize that all people aren't equal and their healthcare needs aren't the same. So what we want to do is we want to create this model in which a health insurance carrier can identify those consumers that are higher risk. And there was things behind the scenes at providers too that were called like RAF scores or like a risk adjustment factor. And you were trying to code. And this is a lot of, there's been a lot over the last few years about payments and overpayments to carriers as well. But again, the idea is let's find out this patient. Let's figure out what their needs are. Let's code that properly. Mm-hmm. And by doing so, we're going to get paid more to care for the person. Right?
Yeah. And just to, maybe rewind the clock even one step back, this is all conceptually, the genesis of MACRA and the move towards more of a overall value-based care model, right? Where we're compensating and reimbursing on the right behaviors, and we're trying to change this, the Medicare Advantage model overall to a more value-based care model. And there was a changing to the funding mechanisms of the contracts and the reimbursement rates. And so this kind of,
and even kind of
lineage goes back to that.
Yeah, that's like SGR, like rates, but you're even talking like fee-for-service versus this, right? And so it kind of was like, let's, instead of just paying for codes, right? If you look back historically at Medicare, everything was fee for service. So there was like a CPT code, something done. Someone goes to, so we're talking about the clinical side right now with doctors, but someone goes to a doctor, okay, office visit level 1, I did these things. I'm going to generate these 4 billing codes for, $286, well, let's be honest, $742. And I actually got paid, $186, right? It was accepted with these CPT codes. And the idea was in that model, it incentivized a lot of providers to see you more and frequently, and you want to tack on as many CPT codes or charges as you possibly could and charge more, and you really weren't, in many cases providing a better outcome, and all you're doing is excess billing, right, for the patients. So that was one element that they wanted to eliminate and say, hey, well, why don't we just make it be on, outcomes? We want to focus on outcomes instead. So that was kind of driving some of these changes with the value-based care kind of model.
So maybe summarize for, if you haven't been in the industry for, if you've been in the industry for less than 5 years in the Medicare Advantage space, maybe you could kind of talk back about how it used to be 10 years ago, and then post-MACRA and post this, introduction of VBID. What are some of the benefits that have been kind of added in or utilized or that have made their way or proliferated into the plans?
Yeah, so even winding it back, so if you go back 10, 15 plus years, and so you again, that model I described about accessing care, CPT codes, billing, everything else, they wanted to overhaul that from the clinical side, change it to outcomes, which they did, and then they started introducing things like the HEDIS measures, star ratings, other things like that. So right now I'm talking about doctors and their payments, but I'm going to get there. It's all tied to the carriers, because if you look at the supply chain, you look at CMS, you look at actually like, PBMs, then you look at the insurance carrier that's creating the insurance product, going down to the healthcare delivery of the consumer. They're all related, right?
So VBID would be an alternative or additional supplemental funding mechanism for these plans.
To the plans.
To the carriers that they could use.
Yeah, so exactly. So the VBID was more, hey, and they would apply that same thing in the supply chain down to the providers and the consumers. So the Medicare was saying, hey, let's give additional funding for these people that have these health conditions, these social determinants of health, these people that need these other health outcomes. Let's provide a mechanism or a means for extra funding to solve that issue. So I think that was the premise or the theory behind it. And again, it's like, well, yes, of course this is going to be more expensive. Like what I'm really baffled about in this decision on the VBID is the reason that they wanted to eliminate it is it's a cost savings mechanism. And of course they're saying, and look, I am all for the record, government efficiency, cutting spending, let's tighten the belt, let's get our house in order. I am completely for that and understand it, like, for the record. But it's confusing to me that they're quoting that, hey, this program, like we've done an analysis, and it's an extra $2.2 billion or $2.3 billion a year, from our analysis, and it's just not worth it so far, so to speak.
I know where you're going to next, but my interesting analysis on that is they talked about that was 2021 and 2022 being 2.1 and 2.2 billion dollars in funding there on the way out the door. What would it have been? I'm sure it would have been more in 2023 and growing.
COVID years. Yeah.
But they, the justification that they gave for eliminating it on the change of the administration is, well, that it's too much of an impact to the Medicare Trust Fund, right?
Correct.
Which there's some interesting other alternative things that had decisions that they'd made just 6 to 8 weeks prior, where apparently they weren't that concerned about.
Yeah, I talked off camera with Mike, and I go, okay, understand. Like, so this is, again, one man's opinion. I look at this decision to eliminate the VBID model, and I go, okay, yep, we're trying to save costs. Cool. And there's more we'll dig into, but, at the same time, if I were to look at that amount for a running 2 or 3 or 4 year period, and you go, okay, that's going to be, $8-9 billion over, multiple years. Well, but the same entity just weeks back before the E word, I'm banned. Edit that one, Mosiah.
Mosiah's like, oh crap, now I got
to edit it. But before that, just decided to do a demonstration period, because it was like, oh, we have the Inflation Reduction Act, and we're just going to do this demonstration period temporarily to bridge the gap, and we're just going to do it. And the demonstration period that they just waved a wand and decided is more than what VBID would be over the course of like 10 plus years?
Yeah, the on the short end of the estimate, it was, around $7 to $10 billion, all the way up to potentially $20 to $30 billion for this 1 year demonstration period. And they were very quick and easy to wave the magic wand, and weren't really worried about the impact to the Medicare Trust Fund on that, because they, had seen what the immediate impact to the Part D premiums and the costs were going to be to the average beneficiary.
Yeah, and I'm not an actuary, don't claim to be. In fact, we joke that we do a lot of napkin math, but I could have gotten out a napkin and pen and done some of those illustrations on the demonstration period for people, or even on this VBID, and go, if I can do that math with a napkin, how could our CBO not do, and that's the Congressional Budget Office for those, how could they not get that right, and why is this a surprise? Like, I guess that's what I'm at now, is going, why are we surprised at this point? Did we not already forecast this? Did we not already run the analysis? Did we already not know that this program was going to cost this much? And at least to some margin of that, maybe it's 10 or 20% or 30% even more than anticipated, but that should have already been accounted for.
Yeah, so there were, VBID was a lot of these plans, and just so I wanted to summarize the impact to this overall, and it's estimated that there are 62 Medicare Advantage organizations or companies.
So almost all of them.
Yeah, almost all of them that are using the VBID model in some way, and 7 million beneficiaries are covered or getting benefits in some way, shape, or form under this VBID administration.
Yeah, so let me just pause that. So if you really think of why we're making such a big deal about this, again, this is one of the big headlines that I think is out there over this last 60 days that is just a headline. It's a blip, but people aren't understanding the context. This is massive, because if you really think about it, to Mike's point there, almost every carrier who provides MA Advantage plans has plans that are filed using this VBID model, meaning that if you're an insurance company and you say, hey, if you want to file your plan design with us, and each time you file a plan, you get a HICN or a PPP, you get an actual number, a contract number with CMS. Well, would you want to, if you were an insurance company, would you want to file a plan that does not have VBID models and incentives in place for your consumers, or would you or would you not want to? Well, of course you do. Of course I want to file a plan that has the ability to receive extra compensation and coding and identifying all these different health factors and be eligible for extra dollars. Because again, if you really look at how things are done, we have MLRs too, and 85 cents on the dollar needs to go into plan design and benefits for consumers. But if I'm eligible to receive more dollars for my plans, I can make my plans better and more attractive, with more co-pays, with more supplemental benefits, with more goodies. And, of course, I'm not going to limp into the market and go, I don't want to file my plan to be able to receive that extra compensation. Pass.
Well, and if I'm a carrier and I'm an actuary and I'm building the plans for the carriers, one of the really frustrating things was a lot of these benefits, let's say like grocery cards, gas cards, transportation, all of those kind of things are the types of benefits that are tied to VBID. A lot of those plans had been doing that with the SSBCIs.
Correct.
Prior, or in addition to, and then in the CMS nerfed the SSBCIs.
Pause that. So just so people know, that's called like special supplemental benefits for chronically ill. That's what SSBCI is.
Yeah, and we've talked about SSBCIs in the past before, and a lot of the dual plans and a lot of these people that are getting these benefits to solve these social determinants of health had been filed under the SSBCIs. And, of course, the carriers, like we always say, show me your comp plan, I'll show you the behavior. Yeah. Where's the money? Where's the financial incentives? And so they started overutilizing these SSBCIs. And in the call letter going into the 2024 plan year, they really limited and nerfed the utilization of the SSBCI model and cracked down on that. And so a lot of the carriers just last year shifted and said, okay, well, we've kind of cracked down on that, and that's not the way it's supposed to be done. So we'll move it to this other VBID model that's supposed to be exactly for this. And then here we go again. We've moved the cheese again. Actually, the cheese has been completely, taken away.
And going back to the SSBCI, they were filed, and what happened is they had a lot. It was broad. It was they could file things under SSBCI, and it wasn't as specific. And then what happened is you started getting into situations where, you know, they were basically approving air conditioning units and pest control and all kinds of things under SSBCI.
Papa Pals and Teddy Ruxpins and
the sad lonely kitties that we talked about.
The Teddy Ruxpin.
And so,
Mosiah, see if you can get an image of a Teddy Ruxpin up here.
Hi, my name is Teddy Ruxpin.
So those are all things that were covered under SSBCI and Papa Pals and Helper Bees and anyways. So at some point they said, you hold on, you got to show us how this is going to improve somebody's actual health as far as an outcome. And instead of filing and getting the data later, you are now going to have to do a whole case study. You're going to have to provide us with the information. You're going to have it in advance, and we're going to have to approve it before you file it. And so it put such a burden onto the carriers to do that they finally said, okay, I guess we won't do it. So to your point, it became more difficult. They stopped doing that, reverted back to having some of these benefits in with just VBID. But so now we're in this situation again where, you know, that if that extra funding mechanism for VBID's not going to be there, and let's just say moving forward, well then what is that going to do for plan design?
Benefits. I mean, obviously it's going to reduce or eliminate, and for those old heads who have been in the industry for a long time, back in the day, you didn't get even really good dental benefits. You didn't get Papa Pals.
One or two preventive visits
you didn't
a
get
year, period.
You didn't get any grocery card or an over-the-counter benefit. You got the nuts and bolts of co-payments and, you know, whatever was covered. And if you were lucky, you know what, maybe you got 2 preventive dental visits. We're either going to see...
Maybe you got $50 towards your lenses.
Correct. We're probably going to see a return to those days benefits-wise, and the carriers will probably go back and start adding in like ancillary add-ons. You know, okay, you want to add on this little, you know, bundle tiered package where you get some dental and vision and some over-the-counter riders or something like that. At least that's what it's currently looking like. Right. But if I'm a carrier and I'm going, man, MLRs, you know, were rough. We just took a beating on the star ratings. We're in contention with CMS on that. We're looking at the funding environment. We're getting, you know, a haircut on the VBID stuff now. I think they're all, you know, the rumor is, and maybe some of our carrier friends, because, you know, everyone's just kind of coming back to life after the holidays, reach out to us. But I'd be pretty, you know, scrambling to kind of see how that's going to look. And I think that it's already going to make plan design and bids for this year look a little bit chaotic.
Degraded.
Yeah, no matter what happens, you know, unless the current administration rides in on a white horse and unlocks a bunch of funding for these carriers, which, you know, all signals seem to be we're looking to tighten the belt first.
Yep.
I think that what this is leading towards is another year, you know,
Chaos.
where it's going to be a little bit chaotic and it's going to be a little rocky, and plans are going to maybe even take a little bit more of a step back.
Yeah, so jump into there. We've talked about it on the podcast here where going into this AEP, you almost had multiple categories of plans and carriers where it was like, hey, we actually want to grow. We're profitable here. And so, it's foot on the gas, go sell, sell, sell. Here in these areas, don't know, non-commissionable in those areas. And those non-commissionable zones kept popping up more and more and more all throughout AEP. Dang it, we got too much business. Now that's not commissionable. And then you had the others where it was like, hey, we got a plan exit all these other areas. So you already had this very chaotic, you know, county by county, plan by plan map of the whole U.S. of chaos. And what we're really saying is now plans were already struggling under the current design with the reimbursement rates, with the reduced, you know, with the disputes over star ratings to make it work. And then the other thing is you have this TBC with your plan designs and your bids where you can only reduce your benefits by so much every year. And that was put in there to protect consumers so that you couldn't have a carrier come in, make a really sexy or great plan one year, and then kind of pull the rug out from under them and really decrease your benefits.
Yep.
And so that mechanism is there. That's why so many plans had to just pull out because they were like, we're so sideways with our funding, we can't be profitable. And because of these restrictions that have been put in place by TBC, we can't reduce our benefits enough to stay in the market. We just have to leave because of the regulations and the rules. So now when you're looking at that landscape that already existed, and you now say, hey, we're also going to eliminate the VBID rolling into this next year, and that funding mechanism is not going to be there, and you're not going to be able to get some of the extra dollars for some of these consumers to solve some of these issues, social determinants of health or other things like that. It just compounds the issue, and you're going to have carriers scratching their heads right now currently in their bid design, trying to figure out, okay, if these additional dollars go away, can we even reduce our plans enough for 2026 to stay in the marketplace? Or are we making more plans non-commissionable? Or are we just going to yank the rug out and eliminate more plans? So that's why CMS put in their letter, I will just say they downplayed it a lot, where they said, oh, you may be able to remain. That's why they're saying you may be able to remain on the plan, because it's undetermined whether the carriers are going to be able to make the numbers work with the VBID being there. So that's one thing that I really think is super important, that we're already seeing. It's January. If things go through as is, that's what we're looking at for 2026 already. Well,
another impact, for the VBID stuff is the way that they kind of use that slush fund VBID on DSNIP plans and LIS plans. Correct. They use that to offset a little bit of the Part D cost sharing stuff as well. So you're just going to see, again, increased difficulty on funding. The dollars are getting even more narrow, and so the carriers are going to have to be even more and more selective as to what kind of benefits they focus on. And this puts a position, and this is I'm anxious to try to talk to some of the lawmakers and some of the carrier reps in the next 60 to 90 days and kind of see where their thoughts are. But if we have another year where like you're talking about, where the funding environment is really rough, and some of these carriers and a lot of these plans have been on the tilt, and we see more SARs, and we see more eliminations, and we see more insurance carriers frankly go, this just isn't worth it. We gotta just get out of the Medicare Advantage space in general. I think we're going to see a major, that 2 years of doing that is going to be a major step back of 15 or 20 years of building and promoting the Medicare Advantage program.
But building trust.
And and building trust and confidence in that with agents, with beneficiaries. And I'd be really surprised, if this administration, because by all, thoughts, at least historically, people like to tend that Republicans like more, they do like Medicare Advantage. They do like the way the public-private partnership. They do, want the funding to be there. They do believe it's a good model.
Right. But I would say
time is of the essence.
Yeah, and it doesn't matter, the consumer and the voter and the constituent and our fellow Americans. By all surveys, the lion's share, the majority of them, really like the Medicare Advantage program. And so they like the plan. And so it's interesting, it'll continue to kind of get degraded if it goes as is. And will that change public opinion? Of course. That's going to look very messy if it stays as is. So that's, yeah. And we've been talking about a little bit the dollars and the incentives that are in place for the insurance company. And the one thing that I'm going to kind of rewind on too is that, well, if I'm an insurance company and I create a Medicare Advantage product and I have these incentives in place where if I do X or Y or Z and solve some of these social determinants of health or code certain things on my members, that I'm going to get paid more, then I as the insurance company now need to go find a way to solve that and do that very well. And so what a lot of these carriers have done, and we've seen over the last 10 plus years, is we have seen them either go and buy and acquire clinics, doctors' offices, facilities. Mm-hmm. We've seen them, if they don't acquire them, engage in contracts with, all the value-based providers of the world. Anything from if you understand and you're listening, like the Oak Streets, the ChenMeds, the Archwells, the Centerwells, the Optum, you name it. All these value-based providers that are out there
that are already under an extreme amount of pressure.
Yes, and so when these insurance carriers go to negotiate these contracts with providers, they're saying, hey, we want to reimburse you this for treatment, and the doctors and providers are always like, we need more money than that. Okay, cool. If if you will help us achieve these things that we need, we'll give you this contract that is also has incentives in there for you. If you will help us to essentially upcode our patients, identify these things, adjust their risk scores, do all these things, we get more money on our VBID design, and we can therefore pay you more money too if you'll help us in this overall process. Okay, great. And they agree on those terms. And so that is another element too that people may not be realizing, that is, if the money for the VBID goes away as well, then that provides less dollars for the carriers to go and engage in those kinds of contractual relationships with providers. It means that just less dollars to be had to bring in those quality network providers, sometimes those teaching hospitals, those niche providers, those marquee clinics or physicians that at the moment they can afford to bring in network, but they may not be able to in the future. So this is also going to have big impacts on contract negotiations with providers and how robust a hospital and doctor and ancillary provider network is going to be with a lot of Medicare Advantage plans too.
Yeah,
so.
I think too, if I'm looking at the carriers behind the curtain, and historically right now, they already kind of know where they obviously landed with their plan design. They already know what changes they need to make. They're about to start, circling the wagons to go to what they call war games and then go into the bid process. And last year, 2024, we saw a delay or a disruption of the normally typical industry timeframes by about 60 to 90 days.
Yep.
And I think that's, I hate the phrase, the new normal, but I think that's
That's a COVID phrase.
That's why I hate it. It's going to be, this year is going to be similar, because if I'm a carrier, I'm probably going, okay, there's all this stuff that we're talking about swirling. Let's, the new administration's coming in. We don't really know how any of this is going to land. Let's slow play this. And so I think that the carriers, again, are going to be scrambling a little bit and playing a little game of chicken like we did last year.
Yep.
And so we're probably going to see very similar to what we happened last year, where we start going to these national carrier rollouts as early as, we went to Devoted's last year the first week of June.
Yeah.
And usually the plans have some sort of first looks or previews of what they're, where they're expanding to, where they may be retracting, a rough idea of what those benefits are going to be looking at. And it was a whole lot of nothing really, other than here's what we're doing as a company. And basically all these insurance carrier rollouts were like that until, honestly, we didn't start really knowing how things were looking until September and early October. And I think that we're probably looking at a year maybe similar, just because they're going to have to wait and see how some of the, how the cards fall, and then kind of make some decisions for there. But I'm expecting, a delayed timeline compared to what it was prior to 2024.
Yeah, and I would just say too, like we're not trying to be. I tend to not be the pessimist. Truly, if you know me as a person, I'm typically very optimistic, and that's just my nature. I'm optimistic. I'm not the pessimist. I'm not trying to, scare everybody and be Chicken Little. But there are some really significant, issues that we're currently having to deal with. Even with this, you're talking. I agree. It's going to be chaotic this upcoming year. Off camera, I have had a lot of discussions with carrier partners, with agents, with broker partners. We all feel like this last year was just brutal. Maybe the hardest year in the last 15, 20 years in the industry. It was rough. And to your point, I don't know that this year is going to be any better or easier, just candidly. And
even though last year we did grow by about 87%. So
we did absolutely crush it.
But it was harder.
But
I wonder if we could have grown
year,
more.
That year took 2 or 3 years off my life, though. So, but we did crush it. And I will say, so setting the table for it's going to be really, really messy and painful. But there's another couple components. And the reason why I'm saying this is, again, I'm bullish on ACA and on Medicare Advantage, Medicare supplements. If you're a broker in the space, if you're a carrier, I am that optimist. I do think that we're just there. We're at this inflection point. It's a little bit ugly right now, but I think the long-term outlook is great. We have this weird period where we haven't really addressed the elephant in the room, which is the Inflation Reduction Act. We just did this bridge demonstration period to kind of solve it for the calendar year 2025. But if we don't do anything to address that with the costs of how it's capped and how the carriers all accrue that at the $2,000 cap, and it's all paid to the carriers, and if we don't address that, you know, the Inflation Reduction Act with, you know, now the VBID going away, with the current funding environment and reimbursement rates, you know, all these things
Cost of care is still extraordinarily high.
with them all
Inflation.
just kind of stacking up into one. And then some of the measures, like when, again, what I'm saying about eliminating the VBID model is I'm not being critical of doing it if you have another plan. Typically, I want to say, hey, what we're doing is not working, but we're going to do this instead. I'm okay with that. But what I don't like right now is the philosophy and the explanations. And if you read the executive summary, you go to CMS's website, read about it. They're saying, well, we're eliminating this because some of these programs like food and transportation, some of these other things, they already exist in some of these other plans anyway. And it's like, well, they may exist to some degree or another, but they're not going to exist to the magnitude that they are now. So, but that was their justification, saying
Even for the chronics and the duals.
Yeah, they're like, well, we don't have to have this here because it's already kind of existing. Well, no, those things continue to get cut, and they're going to continue to get cut. So to kind of, let's just be transparent about it is what I am trying to say. There's not really a new path forward in a plan and saying, we're eliminating this, but here's our plan to replace it. That's what I struggle with. And there are some things coming for 2027 with like the $2 drug list, you know, and generics and other things. But, you know, what happens in this interim period, this 2026 period, you're kind of in this just limbo mode of, okay, well, so there's all these exorbitant costs coming, and we don't have a solution for the the burden of the cost of the Inflation Reduction Act to the carriers, and they're having to finance people's drug cost with the, what do you call it, the PPP, the prescription, forget it, payment prescription plan or whatever. So
you
now,
say PPP, I'm like, that's
I know.
freaking COVID loans. Like,
I know, but so now you have the prescription plans that they're having to reserve capital for. You know, you got all these things coming, and it's like, where's the stopgap measure for 2026? I don't see one right now, and so I think that's what I'm really in. I wouldn't say concern about, but I'm scratching my head and asking the questions to say, okay, well, what is going to be done? You know, path forward to solve some of these things. They just seem like at the moment, there's not really a solution to address them.
Yeah, I mean, best case scenario, you know, hopefully we can, you know, find some smart, common sense ways to cut budget of the overall federal government that will allow for some easing and some additional funds to properly fund, you know, the Medicare Trust Fund and things like that. I mean, that's the easiest but yet hardest solution to actually execute, that would solve a lot of these things, and then just make sure that, you know, everybody in the ecosystem is being good stewards of the money, from, you know, the carriers down to, you know, the agents, and that that we can cut and eliminate any fraud, waste, and abuse where it may benefit from. But the reality is just costs a ton of cash to operate the healthcare system that we have in this country for the amount of people and the current healthcare conditions that we have. Yeah.
So, and to clarify, I'm not saying that, oh my gosh, this is, you know, they're cutting money to Medicare Advantage and that's a bad thing. I'm not necessarily saying, in premise, I like the idea of, again, all government programs and reducing our, you know, our deficit and, you know, spending that down and getting really fiscally conservative. I actually am a big fan of that. So I don't mind the cut. It's just, I don't see like the plan to go along with it is more what I'm concerned about. And, you know, like I said, I think there's a couple things I want to recap that they acknowledged that were positive from VBID, right? I think a few things they said were, you know, VBID actually increased a lot of visibility on reporting because, you know, in order to get the extra funding on VBID, MA plans had to report back, you know, all these metrics and utilization and different specific supplemental benefits and, you know, all that kind of stuff. And so there was increased visibility and oversight on certain elements of healthcare, which I think they said is a very good thing. You know, so secondly, there was a lot of broadening of types of programs and being a little bit more strategic to address people's specific health concerns. They're saying that was a good thing that came as an outcome from it. So there was some acknowledgement that, yes, this money did some good things. The drawback was it was just too expensive. Right?
Yeah.
So.
Yeah, and again, for you.
Well, and I guess I should say there was some abuse to it too, because they were finding that, some people that were maybe necessarily having certain little conditions that were kind of finding their way in the hierarchy of the codes and being upcoded that maybe didn't really apply. So there was that abuse. But I'm like, well, but you already did audits and did clawbacks and everything else on that anyway. You know what I mean? But
yeah, and I always like we've talked about this many times on this podcast before, is, for carriers, for agents, for beneficiaries, overall, where's the gift in this, right? Where could possibly be the benefit out of all of this? And I do think that, if funding shortages and things like this cause carriers to be more innovative, to be more, cost conscious, to still be able to execute and do what they need to do and provide good service and make a buck. And for agents, there's going to be gifts in this for good skilled agents too. Like, we have a lot of our best agents, even though last year, just like us, was the most difficult year on paper. They probably had some of their most successful or best years ever. And I think that same concept is going to continue in 2025, where, okay, let's say benefits are slimmer. There's less of those type of benefits in there. Well, maybe an opportunity for you to sell some of our great ancillary products. Maybe you can place a good quality, maybe even better functioning dental or plan enhancer through Allstate or Golden Rule or one of those, one of our great partners or something like that. And I think that, for agents, whenever there's challenges, there's going to be opportunities as well.
Yep. I would absolutely agree with that. And, to that point, still bullish on everything. And you brought up we are going to see probably a return or increase of maybe even premiums to going back to, the future as I see it.
Back to the future.
Years ago, before all these enhanced, dollars were around and everything else, you started to really see marketplaces with, here's your zero premium plans, here's your other plans with premiums, and these premium plans, there's something that you're paying for, right? In the premium-based MA plans, you were paying for no referrals required, or like more access, less restriction. You were paying for a PPO rather than an HMO with the restrictions. You were paying for a larger network. Maybe this particular plan had this doctor or facility in their network and the other one didn't. You had additional the sexy benefits that people like, dental or vision or grocery or whatever. And we saw that really back years ago before the money started getting a little bit juicier for MA
and before 000 became the norm.
Yeah, and so that's also one thing to think about is, maybe we see a return of that, of premiums. And so I'm just telling everybody that the sky isn't falling. We're just saying that the landscape's going to change, and maybe we do start to see carriers starting to roll out plans with the premium. And as we're talking about this, listeners may be saying, well, that just means that I'm going to be writing a whole lot more Medicare supplements. And maybe, but at the same time, consumers overall like Medicare Advantage plans. And let's be honest, Medicare supplements are not getting cheaper. You're seeing more and more states going to birthday rules, and you're seeing more and more claims data, and you're seeing those premiums increase fairly significantly. And so, how many of the consumers, they're a great option for people who understand them, who are comfortable with the premiums and the increases, but that's not the consumer for everything, right? Yep. The Medicare supplements either. So as we're talking about this, I don't want you to start thinking, oh, now Medicare Advantage just totally sucks and I'm not going to sell it and I'm just going to sell all supplements. That is not the message. But what we are saying is that the marketplace might start to get, again, a little bit more dynamic. It might not just be a chase to the bottom, all zeros with all freebies, with all groceries, with everything covered. It's going to get, again, more sophisticated. Here's your zero plan. It maybe only covers this network. Here's another zero plan that has this doctor network. Here's another plan with a premium that might have a larger network with more benefits. That's what I am kind of thinking might be the case in 2026 and moving forward. At least from my perspective. What do you think?
Yeah, I mean, overall, I think I'm extremely bullish on Medicare Advantage. I think Medicare Advantage wins long term. I thought it would have already put the final stake in the ground for pretty much everything. But I think that, Medicare Advantage is when it works, is the best model that not just, we have in America, but, if you look at where other parts of the world that have quote unquote the best healthcare systems are some sort of public-private partnership like that, like the Medicare Advantage model. And when it works well, it functions very well. We just got to stop, get it into a good place and set the metrics, have CMS and HHS set the ground rules, and let the free market, let these carriers, let these business people, these entrepreneurs do a good job of executing the game plan. And I think that when we get back to doing that, we'll really start to see Medicare Advantage grow and go back and proliferate and become, like the solution that we think it can be. I do think that supplements may, just because, like you said, state choice and things like that, there's probably going to be a reinvigoration of supplements, and there maybe. I think the funding, it's just not desirable for a lot of people to pay those premiums,
Well, when you're in inflation and you're trying to buy groceries and you go, I'm on a fixed income, me and my spouse, and it's,
Well, even at that, I met with, an agent that's retiring yesterday that's been in the business for as long as we, 20 years.
Yeah.
And we said, what are you doing? He's like, oh, I'm getting on an Advantage plan, And, people tend to think that only the poor and the stupid people and the can't afford it somehow select an Advantage plan. But a lot of times it's the opposite. We have great Advantage plans in the state. And I go, why would I pay a premium when I can be on one of these plans myself? And, I think there's bright days ahead. It's just a little bit challenging. I appreciate the challenge. I think last year was really advantageous for us in the industry overall. I think it made all of us agents have to get much, much better and more knowledgeable about how the industry works, instead of just being able to sit back and wait for the new plan benefits and find out what extra thing you're able to give your beneficiary this year. Things don't always go up.
And a couple quick things, just two things I want to before we wrap. The first is, I would say we've talked about it multiple times too, about we're envisioning an uptick or an increase in ancillary product sales. We were just talking about shout out to Golden Rule, to Allstate, to NCD, to GTL, some of our ancillary provider and partners that we work with. We see their product sales continuing to increase and be a benefit to them in this environment. The reason that agents a lot of times don't just sell a rider on an MA plan, back in the day when you could sell a Humana Gold or a United Healthcare plan or whatever and choose a dental rider, it didn't pay the broker any extra commission. And a lot of times there's restrictions on what they could pay. And so the broker's like, I can either click on this $50 rider and have it be included in this plan and get paid nothing, or I can go sell them this other product and get a $300 commission and the product is as good or better. Mm-hmm. I'm going to go do that. So I think that, for the carriers thinking about, you can bid and do your riders and everything else, they're probably not going to get used widely, because I think the broker community is a little bit more sophisticated, and they're going to find those ancillary providers that we think are reputable, that are good, that are doing a great job in providing the benefits, and they're going to start promoting those packages and sell them as complementary things to the core medical benefit. So I think we're going to keep seeing a lot of that is more what I wanted to, kind of bring attention to. Yeah,
but stay tuned, guys. The VBID thing is, kind of snuck in the radar. Like we said, a grenade on the way out the door. I think that we'll keep watching. Anybody that pays attention to a lot of the industry news knows it's a big deal, and we'll keep talking about it and how it may or may not, really impact benefits coming forward. So
the very, very last disclaimer is just everything is subject to change. Inauguration is in 10 days. And we're just looking at the way the landscape is laid out at the moment. And if there's anything we've learned in the past year, all subject to change. Give us a week, and we could be doing a whole episode about how, just kidding, it's all off. So
everything we said's a moot point.
Yep. All right. Catch you
Thanks,
next
guys.
week.